Today, we're talking about one of the most critical and time-sensitive conditions in medicine, sepsis. We'll cover everything from what sepsis is, how to diagnose it, the life-saving steps of management, and the most recent guidelines. I am Angama Joshua. Sepsis is a life-threatening condition that occurs when the body's response to infection injures its own tissues and organs. It's important to remember that this condition can escalate very quickly, leading to organ failure and even death if not treated rapidly. Sepsis is responsible for up to 11 million deaths annually worldwide, making early recognition and treatment crucial. Let's talk about the pathophysiology of sepsis. Sepsis is a life-threatening condition that arises from the body's extreme response to an infection. The pathogens responsible for this, such as bacteria, viruses, or fungi, release toxins, triggering an overwhelming immune response. This immune activation causes the release of pro-inflammatory cytokines like TNF-alpha, interleukin-6, and interleukin-1, leading to what's commonly referred to as a cytokine storm. Endothelial cell damage results in increased vascular permeability, which can cause hypotension and multi-organ dysfunction. Additionally, abnormal activation of the coagulation system leads to microthrombi formation, further compromising blood flow and causing tissue ischemia. The combination of mitochondrial dysfunction and oxidative stress contributes to cell death and worsening organ failure. The symptoms of sepsis can vary, but typically include fever, rapid heart rates, and rapid breathing in the early stages. As sepsis progresses, patients can develop confusion, hypotension, and difficulty breathing. The hallmark of sepsis is when these symptoms lead to organ dysfunction like decreased urine output or liver failure. Let's talk about how we diagnose sepsis. Traditionally, the SIRS criteria have been used, which look at signs of systemic inflammation such as abnormal temperature, heart rate, respiratory rate, or white blood cell count. However, in 2016, the Sepsis 3 criteria introduced this qSOFA score, a quick bedside assessment tool that includes hypotension with a systolic blood pressure of less than or equal to 100, altered mental status, and tachypnea with a respiratory rate of greater than or equal to 22 breaths per minute. If the patient has 2 or more of these, they are at higher risk of poor outcomes, and these indicate sepsis. The qSOFA score is particularly useful for quick identification in settings like the ER. However, the 2021 Surviving Sepsis Campaign guidelines discouraged the use of qSOFA as the standalone screening tool, recommending the use of the SIRS score instead due to its better sensitivity in predicting patients' outcomes. When assessing any critically ill patient, we must remember the ABCs: airway, breathing, and circulation. Ensure the airway is patent, especially if there is respiratory compromise. In severe cases, intubation may be necessary. Assessing breathing, looking for respiratory distress or hypoxia, administer oxygen to maintain oxygen saturation levels between 88 and 92%, and consider early mechanical ventilation for those with respiratory failure. Circulation must be evaluated for signs of shock, such as hypotension, tachycardia, and cool extremities. Start fluid resuscitation with 30 ml per kilogram of crystalloid solution, and if the patient remains hypotensive, initiate vasopressors. Identifying the source of infection is key to providing targeted therapy. This starts with a thorough history and physical examination. For example, pneumonia, urinary tract infections, and intra-abdominal infections are common sources in sepsis patients. Blood cultures should always be taken before administering antibiotics, and specific investigations like urine cultures or chest x-rays can help confirm a diagnosis. Imaging studies such as an ultrasound or CT scan might be required to find hidden sources of infection like abscesses. Removing or draining the source is essential for controlling the infection. Other investigations that are necessary are the arterial blood gases and the lactate, a complete blood count with the white blood cell differentials. Other tests to assess organ function are the serum electrolytes, blood urine nitrogen, and serum creatinine to test for renal function, serum bilirubin and the liver enzymes to check hepatic function, the international normalized ratio, partial thromboplastin time, platelet count, which is part of the full blood count, and the D-dimer to evaluate for coagulation, and echocardiography to assess heart function. You doing this test should be guided by your history and physical exam. Septic shock is a more severe form of sepsis, characterized by persistent hypotension despite adequate fluid resuscitation, which requires the use of vasopressors to maintain a mean arterial pressure, or MAP, of at least 65 millimeters of mercury. This condition is also marked by elevated serum lactate levels of greater than 2 millimoles per liter. The shock due to sepsis is the classic form of distributive shock caused by systemic vasodilation due to increased prostacyclin and nitric oxide released by the endothelium. However, some patients presenting with septic shock could have hypovolemic shock. This can be attributed to increased fluid losses due to fever, vomiting, and diarrhea if gastrointestinal disease is present, and the endothelial injury which causes increased capillary permeability and extravasation of intravascular fluid. This increased capillary permeability is responsible for the acute respiratory distress syndrome in the lungs. Septic shock has a significantly higher mortality rate and requires rapid recognition and intervention to prevent organ failure and death. Once sepsis is identified, early management is crucial. We follow what is known as the Sepsis Bundle, and these steps need to be completed within the first hour. These include measuring lactate levels, obtaining blood cultures, administering broad-spectrum antibiotics, and giving IV fluids. If the patient's blood pressure remains low, vasopressors are needed to maintain a mean arterial pressure of 65. One of the most important steps in managing sepsis is starting broad-spectrum antibiotics as soon as possible. Time is critical, and the goal is to administer antibiotics within the first hour of recognizing sepsis. After culture results are available, we can adjust or de-escalate the therapy. Empirical antibiotic therapy should be broad-spectrum initially to cover gram-positive, gram-negative, and anaerobic organisms. A typical regimen might include vancomycin for gram-positive coverage, especially MRSA, and piperacillin tazobactam for gram-negative and anaerobic coverage. Alternatives include cefepime or meropenem. There are many other acceptable regimens. These antibiotics must be dosed appropriately based on the patient's renal function and body weight, and therapy should be de-escalated once culture results are available to prevent the overuse of broad-spectrum antibiotics. Typically, antibiotic treatment lasts 7 to 10 days, but is adjusted based on the patient's response and the source of the infection. Fluid resuscitation is the first line of treatment to improve tissue perfusion in sepsis. Administer 30 ml per kilogram of crystalloid solution, such as normal saline or lactated ringers, within the first 3 hours. Be mindful of fluid overload, especially in patients with heart or kidney disease. If hypotension persists after adequate fluids, initiate vasopressors to maintain a mean arterial pressure of at least 65. Norepinephrine is the first-line agent. If the mean arterial pressure still does not reach the target, vasopressin, which is the second-line agent, is added. The dose is titrated based on the patient's blood pressure and overall perfusion. Epinephrine, the third line, should be added if the mean arterial pressure of 65 is still not attained. Some other therapies are necessary for the management of sepsis and septic shock. Oxygen therapy should be given to maintain the oxygen saturation between 88 and 92%, and some patients, especially those with acute respiratory distress syndrome, may require mechanical ventilation. Antipyretics like acetaminophen may be used as a symptomatic drug. Hydrocortisone may be considered in patients with vasopressor-resistant mean arterial pressure. Proton pump inhibitor treatment may be necessary to prevent stress ulcers. Hyperglycemia and insulin resistance are common in septic shock. The goal with glucose control is to keep the blood glucose level between 144 to 180 milligrams per deciliter. If it's possible, always choose to feed the patient enterally. Sodium bicarbonate may be given to patients with severe metabolic acidosis. And because these critically ill patients are at high risk for deep vein thrombosis and pulmonary embolism, heparin should be included in the treatment of these patients. Recent guidelines from the Surviving Sepsis Campaign emphasize on the importance of early recognition and individualized care. They recommend dynamic measures to assess fluid responsiveness and encourage regular reassessment of the patient's condition to ensure the treatment is working. The link to the guidelines are available in the description. Now let's review some questions to solidify your understanding. What are the primary components of the pathophysiology of sepsis? What are the diagnostic criteria for sepsis using the SIRS and qSOFA scores? How do you differentiate between sepsis and septic shock? What are the first R steps in the Sepsis Bundle? When should vasopressors be initiated in sepsis? Hopefully you could answer these questions, or if not, you could get the answers back in the video. See you next time.